Dr. Resnick, and thank you very much to Dr. Edmonds. I really enjoyed listening to and watching your presentation. I really liked your suggestions and examples of the infographics, and I agree with you. I think that is definitely a way that we need to move forward in terms of dissemination of research, but also in communicating with our patient partners. And patient partners is a term that we kind of came up with related to a recent project that we recently completed. We didn't want to call our collaborators patients. We wanted to give them a different title. And at one point, we actually didn't want to use the term patients, but they actually told us they wanted that term to be included. So we included partners to the end of that to make it be clear that they weren't just patients, but they were playing an active role in what we were doing with them. So I'm going to actually share some of our experiences related to that project and focus on a different topic related to Dr. Edmonds' presentations, and that's shared decision-making. And believe it or not, there is actually a link compared to what Dr. Edmonds was talking about and stakeholder engagement and shared decision-making from what we did with our project. So it's actually kind of nice when these things come together. So my big question, and it is just a question, just like Dr. Freeberger, I don't always have all the answers for everything. I think by the end of this brief presentation, you'll know what my answer is to this question, but is there a place for shared decision-making in rehabilitation? And I think some of you might be thinking definitely yes. Some might be thinking definitely no. And if we're really honest with ourselves, some of us are probably lost, maybe, certainly, I'm stuck, or I don't know. I think I'm at that stage where I could be kind of in the middle right now. I like to think yes, but if I'm being realistic with myself, it's probably maybe, hopefully. This is a paper that I really, really liked the first time that I really wanted to know a little bit more about patient engagement. And the first time I came across this paper was actually when we were developing a manuscript describing our project. And the authors really distinguish between different types of engagement. And in this case, they described passive engagement, which is actually the most common. And I think folks in this webinar that have been involved with research are probably, they probably are with this because it is the most common. And that's where patients actually serve as study participants. Tokenistic engagement is a little bit more advanced. Patients actually serve as consultants or advisors. And I think by the term tokenistic, you kind of get the impression that they're serving those roles as consultants or advisors, but they're not really actively engaged. And then the term authentic engagement. And that's what we really strove for in our project, is to really authentically engage not only patients, but also clinicians and other stakeholders. It's definitely more advanced, but this is where patients, and in our case, other stakeholders are true research partners. So they're playing a very active role in the process. And where did they start in this process with our project? Well, we really started at the ground level. I came into our project with an interest in musculoskeletal pain, and those were the only guardrails, if you will. Other than that, we left it up to the stakeholders. We heavily weighted what our patients' perspectives were, but we wanted to really identify topics related to musculoskeletal pain that were important to patients, clinicians, and other stakeholders. As you can see by the figure on the right, some of these are really goals related to authentic engagement as opposed to passive engagement. And in the upper right quadrant is authentic engagement, where you see the potential goals, the potential outcomes, if you will, where there's a higher degree of engagement and there's more ownership for accountability, if you will, from the patient's perspective in this matter. So again, this paper is really focused on patient engagement, but in reality, I think it also is could be applied to clinicians, right? Because as researchers, we may need to engage clinicians in terms of research project development, research question development. So very briefly, this is a description of the project that we kind of completed a couple of years ago. This was funded by Patient-Centered Outcomes Research Institute via the pipeline of proposal mechanism. And what I think I'm most proud about is if you look at the authors on this, not just that I'm listed as an author, and believe it or not, my wife is actually listed as an author because she's a clinician, But there's several authors on here that were actually our patient partners. We also have representation from executive residency coordinators, or directors, I should say, one from a physical therapy residency program, and another from a family medicine physician residency program. We also have representatives from professional organizations, and then we have our representation from somebody from PCORI who kind of helped us out along the way. But I think in terms, as well as clinicians. So we have a real diverse mix of stakeholder entities, if you will, representing researchers, patients, and clinicians. The logo there that you see on the right, I'm actually kind of proud of that too, because, you know, how do we engage our patient partners, if you will? And this was one way that we kind of engaged, all right? They wanted to see increased visibility of what we were doing over the course of a year and a half, 2 years. And one of our patient partners, Doug Scott, who's listed here, on the side, he was a graphic designer. So he actually came up with the logo. We got feedback from everybody else, multiple iterations, and he kind of developed the logo. So we had t-shirts made up. That was the kind of step one, but that was the logo that we used when we disseminated anything that came out of this project. The goal of this project and this mechanism was really to develop the infrastructure and capacity building for our group. And like I mentioned earlier, our patient partners were really considered as joint decision makers, with the only guardrails being that we had to focus on musculoskeletal pain. So we kind of look at that as being authentic engagement, or at least that's what we were striving for. The key deliverables, among other things, included a governance document. And I can't remember if Dr. Freeberger or Dr. Edmonds actually mentioned this, but this is basically the document that we spent a lot of time on, describing who we are, what we're going to do, and how we're going to do it, right? For accountability for everybody involved. And if you talk to our group of stakeholders, they would probably say we spent way too much time on this. And I agree, we did. But I think in the end, looking back, this really set structure in terms of our group. And it was a great exercise to go through. Another key deliverable was to identify important topics to the group. And then from the topics, the way that we actually went about this is we paired our patient partners with either researchers or clinicians who had experience with literature searching. They went off on their way, and on the side, they kind of partnered together and they did their literature search on their topic. It wasn't an exhaustive search, but they did tap into the literature, right? This also comes back to, there was a little bit of education. This is one of the side effects of COVID. You have to deal with the dogs when you do these presentations. There we go. They're leaving the house now. Sorry about that. They paired with either clinicians or researchers to do these reviews, and then they came back to the group and provided a summary. And from that, we kind of went through a consensus voting process to determine the most appropriate topic for the group. So related to what Dr. Edmonds was talking about, one of the top research priority topic was actually shared decision-making for musculoskeletal pain. That was most important, not only to the patients, but the clinicians and researchers. Something that really surprised me was in terms of, we also asked them what outcomes were important to them as patients. And they told us what they described was self-efficacy for self-management of their own symptoms. And we had a discussion of what that meant to them. And at the end of the day, it was really related not only to pain self-efficacy, but the way they described it is my ability to feel confident in how I can self-manage my symptoms. And I thought that was really interesting because commonly as researchers or clinicians, we often think that pain and disability outcomes for musculoskeletal pain might be the most important outcomes to track. And we do, sometimes because we are asked to do that and we have to do that. But from patients' perspective, the outcomes are a little different. And oftentimes in research projects, self-efficacy or pain self-efficacy in particular is looked at as a predictor for other outcomes. So again, that was a real interesting finding to me when we met as a group. And another part of this process that was really fun was actually developing this paper, and patients were involved in developing this paper. So in terms of shared decision-making and related to my question, when you look at the shared decision-making literature, Shared decision-making is often used in situations, clinical decisions are associated with a high level of risk, whether that be diagnostic testing, invasive versus non-invasive procedures, or treatment, surgery versus non-surgery. We could also throw in that in terms of treatment, we could talk about opioid medications, low dose opioids, high dose opioids, opioids in general. Okay. With that being said, is there a place for shared decision-making in rehabilitation? Because if we are, again, being very honest with ourselves, and we think about the types of interventions that we provide or we can provide to our patients, in this case with musculoskeletal pain, a lot of the interventions aren't really associated with a high level of risk. They are all very much associated with a low level of risk. And I understand there might be a situation or an example here and there where some interventions might be a little higher risk than others, but in general, they're really low level risk. So again, related to the comment by Dr. Edmonds, shared decision-making as a core of what we do in practice, I think it should be, and I agree with her 100% in that, but I would ask the question, is it really occurring in clinical practice and rehabilitation? And if it's not, how can we improve upon that? So wrapping this up, optimizing engagement and virtual shared decision-making, I think that can address some of the barriers that were discussed. Telehealth, yes, it was a positive disruptor, and I think shared decision-making provides opportunities to add an innovative adjunct to telehealth. I really liked her comments about change management and the need for paradigm shift. The topic about the soft factors, I couldn't agree more that it requires more attention. Ultimately, if the goal is to optimize engagement, they definitely require more attention. Thinking of the patient, situation, and environment. I like the comment about thinking of the patient as the whole person in their environment. Again, very important. And I think that's also related to really gaining trust and having that experience be a true collaborative, a true collaboration between the patient and the provider. And then ultimately, just like a lot of other things, leadership support is vitally important to make this all work. So again, I agreed with a lot of what Dr. Edmonds really discussed.